Şimdi ben
Now, I thank you for this introduction, Ali Safet. I will be quite fast. Either I will talk slowly and you will miss the coffee break, or I will speak very fast. Which one? Which option? Maybe somewhere in the middle. So let me be as fast as I can so that you don't miss out on the coffee break. Now, depression is not my area of expertise. Where I stay in Canada, we have a psychiatry consultation clinic, and I'm in charge of that consultation clinic, and I receive a lot of treatment-resistant patients. In the last couple of 2 years, the patients have been coming with a resistance towards treatment for depression, and pain was an important issue for them. That's why I stepped into this area, and I learned a lot of new things. I've worked in 3 continents in my life, but Canada, Northern Canada, is quite special because there's the insulin tap. With this insulin jab for diabetes patients, and we also have the lidocaine tap, I call it the lidocaine tap. And the patients come, they're depressed, and when I asked them what this is, they say they have a pain. I went to the pain clinic and I was given lidocaine tap. I was given a lidocaine tap by the specialists. Why, I asked, and the internists, although they couldn't find anything, in order to make the pain go away, they put these lidocaine things on the belt, and it's like a tap. And the patients manage themselves somehow, but we oppose this. And my talk is about the relationship between pain and distress. And I don't like to use lidocaine or codeine for patients. And I talked to the other specialists. And at the end of my speech, I was criticized heavily. Why, I asked, and they said, this is a free country and we can even prescribe morphine to the patients and codeine as well. Why are you restricting us? But I said, look, these patients are getting morphine, codeine, and then you send these patients to our clinic and then they're depressed and we can't treat them. That's why I wanted to study this area. So let's be as quick as possible. Depression, my views vis-a-vis depression. Years ago, 2 millennia before even, depression was defined as a medical condition, and with dementia and neurological disorders, I think the internists should know more about depression because it affects the brain, mental health, and the physiology of the patients. And even on the papyruses, you had information about depression. Now, let us also skip this, or maybe very briefly, let me show you this. Depression is associated with emotional symptoms, by and large, and also there are physical symptoms as well that are quite salient, and also there are the associated symptoms. These are general symptoms, and these are all medical symptoms. And because of this, I believe that depression is a disease of the body as well as the mind. But which one comes first? We don't know whether it starts at the brain and then affects the body, or vice versa, or whether they start simultaneously. We don't know yet. Painful physical symptoms. And how to treat this condition. This is an open area. That is to say, there are many unanswered questions in this area, and there are new studies that have been initiated on this, and we really don't know what sorts of messages we are sending, whether we call it chronic painful physical conditions, medically unexplained symptoms, or somatized symptoms. We don't really know yet which terminology to use. As far as I'm concerned, I think we still haven't figured this out. But as you know, especially family physicians, see a lot of patients coming with a complaint of pain. I think these patients, should be checked in terms of depression. As I said, depression, I believe, is a systemic disease. It affects the whole body and the whole system. It's a systemic disease. And I addressed cardiologists and internists in Canada, and I told them, look, because we have this critical care unit, cardiology, for cardiology patients, inpatients, and I said, forget about ECG. I said, do Madras instead, or Hamilton. If the patient is depressed, treat that, and the heart will improve simultaneously, I said. But they didn't take this well. And this is what I showed them. I said, look, in depressed patients, actually, their whole system is affected. So I said, you're losing your time when you overlook depression. And these guys, these specialists, they do not assess the patient's depression. They give beta blockers, they try to reduce blood pressure, treat arrhythmia, but no, you have to look into the eyes of the patient. And I have this Turkish approach towards things which they do not necessarily get in Canada. So there is this mechanism. All of these things have been published. There are so many articles. And with stress, ACTH is elevated. When the ACTH levels are elevated, cortisol and catecholamines damage the heart and cause arrhythmia and ischemia, myocardial ischemia, and also platelet activation comes into the picture. And in the periphery, cytokines and interleukins are affected, and this may contribute to atherosclerosis and eventual hypertension. And this is triggered by depression. And I also ask my students and my residents as well whether depression causes diabetes, and everyone is at a loss. But yes, it does cause that because cortisol antagonizes insulin and contributes to dyslipidemia, type 2 diabetes, and obesity. And also these patients' immune systems are suppressed. That's why they encounter many other problems, and they're more susceptible towards flu and cold. So I believe that depression should be seen as a medical condition. Not just psychiatrists, but neurologists, GPs, internists should also know more about depression and treat depression. As for pain, culturally, we have certain patients, and sometimes people love pain in this geography. But let me show you this. There are two types of pain. One is, we have some singers that are quite famous in Turkey. They sing painful songs, and they are very popular. When I saw this, this was like an epiphany for me. This explains something very interesting. There are two types of pain. The first type is the regular pain, physical pain. And it's very easy to try. When you touch a hot plate, when subjects are asked to touch a hot plate, there's a reaction. And the other sort of pain is social pain. There's another phenomenon called social pain, and this is how it works. Social rejection, or breaking up with your loved one, and listening to these painful songs, or mourning for your lover, tormenting yourself, and so on and so forth. These are two different sorts of pain, and fMRI imaging is performed on these when there's a physical pain. So that is to say, when you touch the hot plate and when your fingers burn, what happens is in three areas, in amygdala and in the frontal part of the brain, there is an activation. This is rather like a network. And when you are dumped by your wife or husband or whatever, when there's a distress in the family, and when that person is subject to fMRI, the same thing is observed, just like as if the person touched the hot plate. So social pain and physical pain. I mean, when I was a medical school student, I couldn't really explain this, but now we can explain social pain. The biology of social pain and physical pain are very much alike. Now, these types of pain, whether they really exist or not, there have been certain studies, large-scale studies as well. These are the most common pains: headaches, back pain, neck pain, all sorts of pain here, abdominal pain, general pain. So 65% of our patients with MDD, major depression disorder, have pain. Only 35% of the patients do not have pain. So pain is a very important problem. And when you look at the distribution of this, you see that by and large these types of pain accompany depression. Does depression start with pain? Yes, in general, 70% of the depressed patients, depression starts with pain. The onset is accompanied by pain. So I believe this to be the case. There is depression with pain, and there are different reasons for pain. And neurologists and internists sometimes overlook pain, but there is pain in certain patients. And for these patients, when we receive those patients, we need to review their depression. Because if we do not do that, if we don't diagnose them with depression, every time they come, they go to the internists or to the family physicians, what happens is they are given codeine, paracetamol, morphine. In Canada, lidocaine, TAP is quite popular. So these are prescribed to the patients, but these cause certain side effects like constipation. They also aggravate depression. So the patient is locked up in a vicious cycle, and we need to know this better. The more we know it, the better diagnoses will we be able to come up with. And in these patients as well, there's polypharmacy problems, adverse drug events, narcotic and or benzodiazepine dependence or addiction. There's another addiction problem as a result, and during the day, because of the side effects, these patients are actually lost due to wrong diagnosis and wrong pharmacology. That's why we need to know these well, and that's why we need to diagnose our patients very carefully. Now, as a psychiatrist, you see patients, depressed patients, and they have residual symptoms. Which symptoms? Anxiety, pain, any unresolved problems. We need to look at those first, and we need to ask the patients whether they're suffering from pain. Look at their prescription list. If they're taking morphine or Novalgin, Paralgin like painkillers, you need to ask these patients whether they have pain-associated symptoms. And because of the fact that internists and neurologists can't explain or account for the pain, we may need to switch the antidepressants for these patients. I showed you that there's a link between social pain and physical pain, and they are very much manifested in the brain in the same manner. And there are actually two neurotransmitters at play. One of them is serotonin, and the other one is noradrenaline. Let me also skip these, the pathway of the pain. Usually, these two neurotransmitters are at play. This is the physical pain's initiation, and it goes up to the spinal cord and reaches the brain, the amygdala, hippocampus, and serotonin and noradrenaline is seen here. And this is my final slide, and I will finish on time so that we don't miss the coffee break, because that would be painful as well, wouldn't it? It could cause social pain. Anyway, let me walk you through the system in Canada, the guidelines in Canada. For chronic neuropathic pain. And also let me tell you what I do and what I use. First of all, when the patients come, for painful patients, we either give additional tricyclic or gabapentin or pregabalin. That's the first option. And secondly, duloxetine or topical lidocaine is given to the patients. And the third option I never utilize, tramadol or opioids. I shun these. Chemical cannabis, I mean, it's available in Canada. There are other options. I never use them. What I do is when the patient comes, if the patient is on codeine or on morphine, I taper them off, because if you do it immediately, you cause withdrawal syndrome. So you need to titrate down incrementally. And again, based on the patient, I either use tricyclic, TCA, or I usually use gabapentin or pregabalin at night. And that also gives them sleep. And also gabapentin and pregabalin are have low side effects. That's why I give them to my patients. And when I taper them, the risk becomes even less. As for antidepressants, I give them SNRIs. I showed you previously serotonin, norepinephrine are affected by these. And as for glucosamine, there are so many studies for antidepressant, anxiolytic, and for knee pain, chronic neuropathic pain, diabetic neuropathic pain, indications are available. And duloxetine I give to these patients, or I change it. Effexor, Valnasaxir, can they be used? Yes, but the dosage may be a bit too high. 225 milligrams of venlafaxine is still an SSRI, so 300, 375, above 300 might be needed to get an SNRI effect out of this drug. Main antidepressants, their indications in Canada, the duloxetine has been studied, and for knee arthritis it is even indicated. A study was conducted on these patients and it's been indicated, and all the other drugs have different indications. Paroxetine for PTSD, the others don't. So each and every antidepressant has its ups and downs. Thank you. We also would like to thank you. Any questions, please? There are 2 questions. Very quickly, please.